Welcome to Season 2 of Nuclear Matters from the Australian National University. I'm your host, Liz Williams, Interim Director of the ANU Nuclear Stewardship Network and Nuclear Systems Discipline Lead for the ANU School of Engineering. I thought I'd start the season off with something a little different. Technologies that are in fact radioactive cocktails that have been carefully designed to treat cancer from within. My guests today are Ashleigh Hull and Stephen Tronchin. Ash is a nuclear medicine technologist and lecturer in medical physics, and Stephen is a postdoctoral research fellow. Both work at Adelaide University and are part of Radinnovate, an Australian Research Council industrial transformation training centre focused on developing the next generation of nuclear and radiation science researchers for Australia. Both Ash and Stephen work on different aspects of these kinds of radioactive cocktails, known as theranostics. Let's listen in. Hi, Stephen. Hi, Ash. Thank you so much for joining me today on the Nuclear Matters podcast.
Thank you. Good to be here.
I thought I might start with a broad overview of the work that you both are doing. And the word that categorizes the research that you're both involved in is theranostics. So can you tell me what theranostics is?
So as a bit of a general overview, theranostics is the treatment approach in nuclear medicine that combines a diagnostic scan with the therapy, hence the name theranostics. And basically it involves the administration of a radiopharmaceutical, which is essentially just a molecule that also contains a radionuclide. And this is commonly injected intravenously into a patient. It can also be injected, say, straight into the tumor or given as an oral tablet, which is the case for iodine therapy. Mm-hmm. So the core idea is that the molecule, it's designed to bind to specific features of a disease, such as a receptor that might be overexpressed on a cancer cell. And firstly, a diagnostic scan is performed where this molecule is labeled or joined to an imaging radionuclide, such as a positron emitter for PET imaging. And we do this imaging just to confirm whether the disease expresses the target and sort of where it is in the body.
Can we break this down a little bit? You mentioned receptors on tumors, right? Tumor cells. What is a receptor? What kind of purpose does it serve in the body?
Yes, so all cells express receptors or antigens or peptides, which are just required for all kinds of cellular processes. Whereas on cancer cells, you might have certain receptors that are just overexpressed. So there's like a lot more of those specific receptors. Mm-hmm. So then if you design a molecule that's sort of targeting that receptor, you sort of get more of that molecule bound to the cancer cells compared to normal cells just because of this excess express of that particular receptor. So you're sort of able to get higher binding to the tumor cells compared to the normal healthy tissue.
Okay, so basically you have the special molecule that will bind preferentially to these receptors. The cancer cells have lots of these receptors. The molecules that you're creating or using in theranostics, they basically have a component that produces radiation, right?
Yeah, so the molecule, there's different parts to it. So there's like the targeting vehicle, which is the part that's designed to bind to those overexpressed receptors. Mm-hmm. And then to the targeting vehicle, you kind of label it with a radionuclide, which is essentially just sticking on a radioactive atom onto this molecule. Mm-hmm. So then the targeting vehicle will hopefully bind to the cancer cells, those receptors, and then that atom will decay, releasing radiation.
Okay. So you're mentioning that there is a diagnostic part and then there's a treatment part. And so for the diagnostic part, you've attached a radioactive isotope to that molecule that you can use for imaging, right?
Yes. So for the diagnostic scan, you have this molecule or the targeting vehicle, and then, you basically attach a radionuclide that is good for imaging. So it could be a positron emitter, which is good for PET imaging, mm-hmm. or just a gamma ray emitter, which you can image using SPECT imaging. And that's really just to image the biodistribution of that molecule throughout the body.
Okay. So for PET scanning, so if you've got a positron emitter, what you're actually doing is you're basically making it possible for that positron to interact with an electron and put out to 511 keV gamma rays, right? Another direction, correct?
Yep, correct.
You annihilate the positron with its interaction with the electron. You put out those two 511 keV gamma rays, and you've got detectors on either side that can pick those up, right? And so by picking those up and looking at the orientation of those two gamma rays, you can pick up where those molecules might be preferentially taken up. Is that right?
Yeah. You essentially get basically a whole body image of where the molecule is in the body based on imaging those gamma rays that come off the positron-electron annihilation.
Yep. And it's similar for SPECT, except you don't have two gamma rays, you've got one, right?
Yeah, a single photon. Yep. So you sort of just use a specific SPECT gamma camera to image the distribution based off of one photon.
Okay. So gamma rays, just for those who are listening, gamma rays are high energy photons, so they're higher energy light. They can go a fair distance, or at least they have the likelihood of going a fair distance. So you can see them coming from the body and pick those up in detectors, gamma detectors. Yeah?
Yep.
And so that's the diagnostic part. And the treatment part?
Yeah, so if the scan reveals sufficient uptake of this molecule or radiopharmaceutical in the tumor, then you know that that patient is expressing enough of, the correct receptor. Then the therapeutic treatment can be administered, which is basically using the same targeting molecule, but now you're joining onto it a therapeutic radionuclide, which will generally either emit a beta or an alpha particle to deliver that radiation dose to the tumor.
Okay, so why do you choose a beta or alpha emitter?
Just because they are better at depositing radiation dose locally. So gamma rays can pass through a lot of tissue and essentially leave the patient's body. So they're good for imaging.
Mm-hmm.
Beta particles have a shorter path length in tissue. They're electrons. So they'll deposit their dose within maybe a couple millimeters, I think.
Mm-hmm.
And then alpha particles even have a shorter path length in tissue on the order of micrometers. So you can really get sort of that local dose to the tumor environment.
Okay. So you're basically trying to destroy the tumor cells, right?
Yeah, that's the end goal.
Okay. So the radiation is depositing energy in hopefully the cancer cells and basically destroying them in that process, or at least there's a likelihood that they will be destroyed in that process.
Yes. Yep.
So what kind of cancers are theranostics typically used for?
So theranostics can be used for thyroid cancer, where we use radioactive iodine for both imaging and treatment. And then alternatively, it's commonly used for the treatment of prostate cancer, using agents that target the prostate-specific membrane antigen, or PSMA. And then we also have some theranostics available for targeting neuroendocrine tumours, which is quite a broad category of tumours that can arise anywhere in the body. And for those neuroendocrine tumours, we're typically using something called dotatate that targets the somatostatin receptor, typically subtype 2, that's known to be overexpressed on those cells, but less so in our normal tissues.
You've mentioned that obviously the cancer cells have lots of these particular receptors that you're looking at, but these receptors can exist on normal cells as well. Is that right?
Yeah, they can. So things like PSMA are also normally expressed on the salivary glands. So that's a factor that when we give the patient the treatment dose or the therapeutic dose, we know that some of that radiation is still going to go to those salivary glands because it's still expressing it. So there's some methods that can be trialled to see if they can decrease the dose to that area. Not always as successful as others, but it comes into deciding whether the benefit is worth the risk of damage to the salivary glands or whether we want to, treat the cancer.
So we were just talking about how some healthy cells might receive a dose with this kind of treatment. I'm wondering if maybe this is a good time to talk about how you balance the dose a patient might receive in treatment with the benefits of that treatment. I know, Stephen, you've done some work on this, so maybe I'll go to you for that question.
My PhD was in the area of dosimetry, so I can talk a bit about that. And I guess in nuclear medicine, sort of as with any treatment, there's always a balancing of the risk versus the benefit. And yeah, radiation can cause harm, particularly to sensitive organs like the bone marrow and kidneys. But in many cases, the benefit of precisely targeting and treating the cancer outweighs those risks. And yeah, as we discussed, a cool part about theranostics is we do that diagnostic scan to start with, which basically tells us the distribution of the radiopharmaceutical throughout the body. So how much is going to the tumor, but also how much is reaching normal organs and healthy tissue.
Yep.
So from that diagnostic scan, we can use that information to essentially estimate the radiation dose to the tumor and healthy organs. And this is essentially what we call dosimetry. So what we want to do is we just want to ensure that the tumor is getting enough dose to make sure that the treatment is effective, but we also want to check that the dose to healthy organs is below certain thresholds and dose limits.
So for listeners who haven't listened to our first season, we did an episode with Eva Bezek, and one of the things that she mentioned, which kind of stuck with me, was that cancer cells and healthy cells respond differently to radiation doses. And I'm wondering if cancer cells are more likely to get killed in the process of being exposed to radiation than healthy cells have some mechanism for repair, or more of a mechanism for repair. Is that correct?
Yeah, I mean, I think cancer cells in general are just a bit more chaotic. So a lot of the repair mechanisms and checks that normal healthy cells have, cancer cells might not have. So they're less equipped to basically repair from radiation damage compared to healthy cells.
Right. The other thing that stuck in my mind is she said that the frequency of treatment kind of takes that into account. So you give healthy cells time to repair before kind of delivering the next dose of treatment. I'm wondering if something similar happens with the theranostics planning process for treatment of a given patient.
So a part of the development of a radiopharmaceutical is trying to work out that optimal treatment schedule. So it's like how much activity to give, but also kind of at what time intervals, like how many weeks apart should each treatment be, how often should the treatments be, and sort of how many they should have all up. So it does take into account a bit of the repair ability of the healthy cells to be able to bounce back, especially for the bone marrow as well, to make sure patients don't get any bone marrow toxicity.
Mm-hmm. So the initial scanning process, does that inform the periodicity of treatment?
Typically, most of the therapies have defined schedules. So it would be like 4 to 6 weeks often between the cycles. It's going to depend on what the theranostic is and also how the patient's responding to it. If they are having, bone marrow suppression and it's not resolving in that cycle time, then they might look at, extending the cycle or giving more time for recovery, or perhaps not continuing with the treatment as well in severe cases.
Okay. So the periodicity of treatment then is sort of based on, I guess, the clinical trials and everything else that informed how a particular treatment gets delivered to patients.
Yeah.
Yes. And then there is the possibility of adjusting that based on how, a clinician sees a patient is doing during the treatment process. Is that right?
Yes.
So there are various levers that one could pull in other words, to make sure that a treatment is working well for a given patient. And it's ideally having the effect that it's meant to have.
Exactly, yeah.
So maybe this is a good time to ask you what makes a good theranostics treatment. I know you're both involved in developing these for different kinds of cancers. What does good look like if you're, coming up with a new treatment?
A good theranostic treatment is ideally about maximizing that dose to the tumor while ensuring minimal harm to healthy tissue. And a main component of developing a good theranostic treatment is starting with a good targeting vehicle. So that, as we talked about, you want the targeting vehicle to bind sort of strongly and selectively to disease-specific targets like those receptors that are overexpressed on cancer cells, and you want to have that minimal uptake in normal tissue. And so that's kind of the molecule parts. And the next part is ideally determining a matched radionuclide pair for the diagnostic and therapeutic components. So a key feature of theranostics is the pairing of the diagnostic isotope used for the imaging with the therapeutic radionuclide used for the actual treatment. The imaging radionuclide will basically either emit positrons for PET or photons for SPECT, and then your therapeutic radionuclide emits those beta or alpha particles. And a good pair is ideally one that's chemically identical or a very similar compound. And as maybe an example of a chemically identical pair is lead-203 and lead-212. So lead-203 is used for imaging, so it emits a photon, which is good for SPECT imaging. And then lead-212 emits alpha and beta particles, which is used for the therapy. And they're elementally matched pairs as they're both isotopes of lead. So basically their biokinetics, which is their behavior in the body, will be very similar.
Right. So basically you're using the fact that a given atom, if it's the same isotope, so it has the same number of protons in it, lead-203 and lead-212, they're both isotopes of lead. So from a chemistry perspective, they basically behave the same in the body, but their radioactive decay pathways are different.
So basically, because, they're both isotopes of lead, so they're going to, behave very similar in the body, but then they have the different decays. One is good for imaging, one is good for therapy. And then that basically, they make a good theranostic pair. And because basically what we want to make sure is that we want to ensure that based on the imaging scan, we are definitely predicting where the therapy will go. So you have to make sure you do have a kind of like a good matched pair.
Okay. And how easy is it to find a good matched pair?
It's not super easy. It takes a bit of time to work out good candidates and good pairs. And there's obviously common isotopes used for PET imaging. Gallium-68 is a common isotope for PET imaging, and a lot of the time that's used for the diagnostic scan, and it's labeled to the same targeting vehicle as you would use for a therapy, such as like lutetium-177 is an example, or a beta emitter used for treatment. So that's kind of an example of like a pair that's commonly used in the clinic. And there is this interest in looking at these elementally matched pairs, which are basically just different isotopes of the same element. And copper is another example that I think has a diagnostic and a therapeutic isotope.
How easy is it to actually bind the part of the molecule that targets those receptors to the radionuclide that you use for either imaging or treatment?
It's really dependent on what chelator you have. So a chelator is essentially the glue that holds the targeting molecule with the radioisotope. Mm-hmm. And different chelators are suited to different elements and different radioisotopes. We have some chelators that we know are really stable with certain agents. For example, if we go back to the gallium-68, that binds really well with something known as DOTA. And so DOTA is essentially the chelator holding those two components together. We also know that the lutetium-177 that Stephen mentioned can also bind really strongly with DOTA. So having the same chelator can help maintain similar biokinetics between the agents. But sometimes we don't always have that perfect combination, and we might need a different chelator for the diagnostic agent compared to what we'd use for the therapeutic agent. And it's really more so about maintaining similar biokinetics, but importantly, making sure that the pharmaceutical is stable in the patient's body. We ideally don't want that isotope, breaking off and traveling freely with no targeting vehicle attached.
Right. I imagine you have to think about how these things are actually cleared from the body over time, yeah?
Yes.
And if they are separated at some point, they might behave differently in the body. Is that correct?
Yeah, so we can have certain agents or certain isotopes can naturally accumulate within the kidneys. So the kidneys are often what we call a dose-limiting organ. So that would be something that when they're performing the dosimetry, they're assessing the kidneys as a normal tissue and making sure that they're not getting excessive amount there, just because it is our main excretion pathway as well.
So that also applies to dosimetry as well. So sometimes dosimetry can be quite tricky, especially for alpha emitters that have a long decay chain, because that issue of their isotopes sort of breaking off the chelator or breaking off the targeting vehicle can happen with the decay of the parent radionuclide, and then the daughter radionuclide can actually be unbound and free to just move around the body based on its kind of own chemical properties.
Right. So let's break that down, because I hadn't thought about that before, but actually that's really important. So when you're talking about alpha decay, what you often have is you have one, like a parent isotope, an isotope that you're starting with. It decays via alpha decay. You get an isotope that has 2 less protons, 2 less neutrons, and that isotope in turn may also decay via alpha decay. So you can have a whole chain of those kinds of things. And so each of those isotopes that gets produced following an alpha decay process will have different chemical properties, right?
Yeah, basically. So you have the parent isotope, which is bound to that targeting vehicle. And then when it decays, that daughter isotope, which can also be an alpha emitter itself, gets detached off the targeting vehicle. And then you basically are left with these 3 unbound alpha emitters circulating through the body, which can be an issue for normal organ toxicity. And so that was actually a part of my PhD project. And a bit of the work I do now is trying to improve dosimetry estimates, especially for alpha emitters, by looking at modeling and simulating the movement of these unbound radionuclides throughout the body. So basically, we're just trying to improve how accurately we can determine these organ doses, especially for healthy tissue. And this information can just be valuable when developing new radiopharmaceuticals, especially alpha-emitting radiopharmaceuticals.
Okay. So the parameters that you're kind of looking at are, first of all, how many steps are there in a particular decay process for a given alpha emitter? What happens as a result of the transformation, or the alpha emission and then subsequent production of a daughter nucleus? And then, how does that move within the body, and what kind of impacts could that have if that can, also decays via alpha emission?
Yeah.
How far do some of these daughter nuclei travel?
Yeah, they can redistribute all around the body. And kind of in the work I did, I find that I found one of the main organs was the kidneys, because that is the main clearance pathway. And I specifically looked at the isotope actinium-225, which has quite a long decay chain. And I think there's 4 alpha emissions per decay of actinium.
Mm-hmm.
So I found that the organ we were most interested in was the kidneys, because there is quite a high clearance and uptake through the kidneys of the alpha-emitting daughter isotopes. And there can be a slight increase in the kidney dose. So that information, can help maybe optimize administered activities in the future.
Okay. So when you're looking, I'm going back to the question that I asked before about a good theranostics treatment, though. One of the things you might consider is actually, what are the various steps in the decay chain, and what are the impacts that might have on dose received by the patient over time?
So there's almost different parts to that. There's having a shorter decay chain is almost better in terms of the redistribution of daughter isotopes, but also having a longer decay chain is almost valuable as well, because then you get more dose delivered per isotope administered. And ideally you want to make sure that the daughter isotopes remain at the tumor location. Is kind of a part of the process. And there's a lot of work on looking at internalization of radiopharmaceuticals to help with minimizing that sort of off-target dose.
Now, Ash, I'm wondering if you can think about this question in terms of patient outcomes and how to optimize patient outcomes with regards to a given theranostics treatment. Maybe going back to your role as a nuclear medicine technologist, how might you think about this kind of thing if you're considering how to treat a given patient?
I think a lot of considerations with theranostics come for both prolonging survival, but also maintaining that quality of life for the patient. So we know many of our theranostics treatments are designed to treat metastatic disease. And traditionally that was treated using chemotherapy, and chemotherapy is known to target both your normal cells and your cancerous cells. So patients can have quite significant side effects, feel quite unwell from that. The benefit of the theranostics approach is that we ideally have increased targeting of those tumour cells, less so of the normal healthy cells, and that can hopefully reduce some of the side effects for the patient.
So metastatic cancer, that's where the cancer cells have spread from the original tumor site. Is that right?
Yes. Yep.
Okay. So you're looking for something that will effectively go through the body and seek out those cancer cells wherever they happen to be. Yeah.
Yeah, exactly. So it's not all theranostics treatments, but a lot of the ones being developed are kind of systemic in nature, being that they travel throughout the body, but still localized and specific delivery to the tumor cells.
Where did theranostics as an idea start?
The original theranostics was developed in the 1940s when they discovered radioactive iodine can be used to treat thyroid cancer. Now, iodine-131 emits both gamma photons as well as beta particles, so it can actually be used for both diagnostic imaging and therapy itself. So it's not a case where we're changing the radiopharmaceutical that's used, we're just adjusting the activity that's administered to the patient. So then we can either image with a lower activity and then up the activity to get a therapeutic effect. So that's really the original theranostics that's been around since the 1940s.
Mm-hmm.
The term itself has got a lot more momentum nowadays and it's becoming more modernized, I guess. And that's through the development of new theranostics approaches like PSMA and dotatate.
You may not know the background here, but I'm kind of curious what kicked off greater development of theranostics. Like, it sounds like there's been increasing sophistication in terms of like how we strategically use both the targeting molecule and the radionuclide for imaging and treatment over time. So was there something that sort of kicked off that process, or has that just gradually developed over time as people have kind of experimented with these kinds of approaches?
I'm not actually 100% sure. We've probably gotten more advanced in understanding cell biology and knowing what receptors are overexpressed on cancer cells and less so on normal cells. So it's quite a multidisciplinary approach. We've got the biologists that are almost identifying those targets, and then the chemists who are putting it together with the radiation, and then the physicists who are making sure it's quite, or like the doses are safe, and then obviously the medical doctors who are overseeing the whole chain.
Now, that's quite interesting. So you mentioned the kind of cross-disciplinary nature of what you do. I'm wondering if that's something that's kind of built into your process, or your training, your way of researching. Are you working with, for instance, biologists, chemists, clinicians to develop these therapies? What does that look like?
Yeah, so within my work, which is quite laboratory-based, we do work with all sorts of other scientists. So we can do the biology work. We have amazing biologists who do identify these targets and who develop the targeting vehicles to bind to those receptors. So if someone's discovered how to develop an antibody that targets the cancer cells or a synthetic peptide, things like that. And then we always have a radiochemistry team who can help to label that molecule with the radioisotope, and they look at the chelation and check how stable it is in vivo, things such as that. And then we've got, the physicists for understanding how it's actually targeting the tumours itself. We can perform biodistribution studies with our biology counterparts to see how the agent actually travels through the body as well, typically in animals in those first stages. And then from that, you can decide whether or not it's worthwhile proceeding to clinical trials, which is where the physicians or the medical doctors can assist as well in kind of determining what patient profile would be best suited for this theranostics treatment.
What is interesting me in hearing you both talk about what makes a good theranostics treatment is the process of creating a new theranostics treatment. I'm wondering if you can, since you both contribute to different parts of this, I'm wondering if you can talk to me about how a new theranostics treatment gets developed, kind of from like idea all the way to actually getting used for care for patients.
For sure. So it does start with identifying an appropriate target, which the radiopharmaceutical will bind to. So that is typically the first part, is this target identification. Is there a receptor that is overexpressed on the cancerous cells but has limited expression on the normal healthy cells? From there, you need to develop an agent that is able to bind to that target. So this could be something like an antibody, it might be a synthetic peptide, nanoparticle, other small molecules. And once you have something that can selectively and specifically bind to the target receptor, you can then start looking at radiolabeling it and then assessing the efficacy of that treatment in cell lines, usually initially. And the cell lines will just give a bit of a generalized overview of, is it binding to the cells? Yes or no? Is it killing the cells? Yes or no?
Can I ask a clarifying question on that?
Sure.
So this is like, you've got cells in a petri dish, right?
Yeah, in like a flask. Yeah.
Okay. And so you're basically saying if the theranostics agent you created binds to those cells, and how many basically survive if you have the radioisotope that's meant to actually deliver a dose.
Yeah. That's essentially, you'll usually have at least minimum 2 cell lines, one which has the target expressed. So the target might not always be expressed by every cell line of that particular type of cancer.
Mm-hmm.
That makes sense. So you'll have one that's sort of your positive control. So you're expecting the radiopharmaceutical to bind and cause a cytotoxic effect in those cells.
Mm-hmm.
And then you should ideally have another cell line that either has no expression of the target receptor or limited to low expression. So that you should see a bit of a differential effect in the cytotoxicity of the agent between that.
How does that compare to what happens in the body? Are you expecting to see the receptors that you're targeting expressed in excess most of the time, or is there variability?
Ideally, it would be a receptor that is expressed most of the time, but it can be quite a heterogeneous sort of expression profile.
Okay.
So, yeah.
So different patients might exhibit a different likelihood that the cells are going to express those receptors.
Exactly. It can be like between patients, but also within one patient's own tumour, they can have different cell types, and some of those cells in the same tumour might have the receptor expressed, others might not, or to differing levels.
So that's helpful in understanding why it's actually really complicated to treat cancer.
Yeah, exactly. So what works for one patient with one disease at the same stage may not apply to another patient who comes the next day.
Right. So you kind of have to have a suite of methods for attacking the cancer cells, and theranostics are kind of one class of approaches, I guess.
Yeah, exactly. It's not a one-size-fits-all approach, but by having kind of the dosimetry aspects as well, you can start to personalize the theranostics approach so that there should be the benefit for the individual patients, hopefully.
Okay. So we were talking about cell lines and testing in cell lines. I am imagining, so that happens to see if the whole idea works, basically. And how well it works given a particular cell line's, either expression or not of that receptor. What's the next step after that?
So once you have kind of that simplistic overview, you can then start looking at how the radiopharmaceutical works in animals. So the animal models will often involve rodents, and you can perform biodistribution studies so you can see where the agent is going to the other organs in the body. And you can also look at how well the agent is at being taken up by those tumour cells when it's given more systemically, so typically through the intravenous injection. Because I guess with the cell line studies, we're directly applying the radiopharmaceutical onto the cells. It doesn't have to go through the blood and essentially find the tumour itself, which is what those animal studies are for. And those animal studies can also give insights into overall survival. Is it actually prolonging survival? Is it not? Is it causing significant side effects to those animals or not? And that will help to determine whether or not the theranostic treatment should progress through the clinical trial kind of assessment.
Okay. And so if a treatment looks like it's doing a good job in an animal or in animal studies, then what happens?
Then you would aim to get onto a clinical trial. So starting with your phase 0 or phase 1 trials and then escalating up. I think Stephen might want to talk a bit more on this one.
Yeah, when doing those early clinical studies or first in human trials, basically you just have a small number of patients that are treated to get an initial sense of how the radiopharmaceutical behaves in the body. Similar to those animal studies, basically just looking at the spread of the radiopharmaceutical throughout the human body and confirming that the tumors take up the agent. And then from there, sort of one of the key parts of clinical development is dose escalation. And that basically means just gradually increasing the administered activity across patient groups to find the optimal balance between the tumor dose while avoiding unacceptable toxicity sort of in those normal healthy organs. And as we discussed earlier, a big part of this process is dosimetry, where we can estimate how much radiation is being delivered to the tumor and to the sensitive organs like the kidneys and bone marrow. And at the same time, there's also very careful clinical monitoring for toxicity. So patients are followed closely for side effects. So they're undergoing regular blood tests, imaging and functional assessments, essentially looking for things like changes in blood counts or kidney function or just other side effects. And these clinical observations are linked back to the estimated radiation doses. And over time, that essentially helps us identify these dose toxicity relationships, which will help us identify thresholds where toxicity starts to occur.
So I want to break that down a little bit. So I think my first question is, how much variability do you see in a given patient population with regards to, when it appears that the risks are outweighing the benefits? So when radiotoxicity is occurring?
Yeah, this can vary quite a bit across different patient groups, and it can depend quite heavily on factors like the burden of the disease, like how many metastases there are, so how much the disease has spread, and it also can depend quite a bit on previous treatments. So if patients have had previous chemotherapy or other types of radionuclide therapy, then there can be this reduced bone marrow reserve to start with. So you might get more observed toxicities in those patient groups. So it's interesting because especially for treatments like, say, alpha emitters in targeted alpha therapy, that is sort of a bit of a new treatment, and it's used kind of towards the late stages of disease. So patients have already had a lot of this chemotherapy or other radionuclide therapies. So looking at their toxicities, sometimes it just reflects more of the previous treatments they've had. So it's interesting when you can do a study where you're using a new therapy sort of more as a first line of defense, and that can give maybe some more insight into the toxicities related to that specific treatment.
This is just making me think about the patients that volunteer to be part of these clinical trials. And I'm wondering if you can talk me through that a little bit, like what kinds of patients are often in the study populations for these therapies?
So for the earlier, for like newer therapies that are still being developed, these patients tend to be kind of like basically looking for a last resort treatment. So normally, especially for a lot of the alpha emitters and alpha therapy, the patients have undergone other treatments which haven't worked. And then they're basically, the clinicians are turning to alpha emitters as a bit of a last resort, because it's used as, I guess the term is a salvage therapy, sort of granted on compassionate grounds for these patients. And that's kind of like what you would do in the more earlier stages of developing a radiopharmaceutical, is you're using it after the more standard of care approaches have not worked. And then you sort of start to use these other therapies which, have the potential to work, but still maybe we don't know 100% the side effects or the toxicities. But because they're at that very late stage of disease, the benefit is essentially outweighing the risk.
Okay. All right. So are there any kind of key stage gates that are important for actually turning a theranostic into something that gets used on a regular basis for treatment?
Yeah, so basically after doing those kind of first in human studies and initial studies and the dose escalation and monitoring for toxicity, if that's kind of going well, you start to move on to these larger trials, phase 2, phase 3 clinical trials, and that's where the focus starts to expand to include patient outcomes. So you're not just looking at the safety, but you're also looking at the treatment effectiveness, which tells us how well the treatment actually works. So we're basically looking at outcomes like, are the tumors shrinking? What's the overall survival and the progression-free survival? Are patients living longer? Is their quality of life improving? So we sort of start to look at the effectiveness of the therapy in these trials. And then a part of that is also looking at how to refine the treatment. So that sort of includes a bit about what we talked about a bit earlier about how many cycles a patients receive and how far apart the cycles are. And then over time, we sort of start to get all this data based on the dosimetry, the toxicity, the patient outcomes from larger trials, sort of all comes together so we can essentially optimize the treatment protocol and work out how much activity to give, how often, and to which patients. And then, ideally you get to the stage where you're fairly confident that the treatment delivers a notable benefit with an acceptable and well understood level of risk. And then it sort of starts to move more to that regularly used clinical treatment.
Okay. And I would imagine that whole process would also inform how you're checking in with patients, what you're looking for in terms of like, what is the impact of the treatment on the patient as a whole, and how do you need to manage that?
Yes, you're always looking at the quality of life of the patients, and checking that as well, because that's an important aspect of the treatment is, you don't just want to treat the cancer, you're also looking at a lot of other aspects that are at play, so ensuring that the patients still have good quality of life, and that, are they living longer, and what are the toxicities, and all of that's at play as well.
So now I want to take a step back and consider nuclear medicine as a field that enables theranostics treatment and innovation. I'm curious about the current state of the field from a workforce perspective. Can you tell me, like, what's that looking like for Australia right now? And are there any, I don't know, maybe are there any messages you might want to share with people who might be considering working in the field?
Yeah, so from a nuclear medicine technologist point, we are in a national workforce shortage across Australia. Most states are kind of at critical levels for how many technologists there are. That's partially because there's limited universities that offer the degree, and it's also because there has been quite a large uptick in the number of PET-CT scanners, for example, and the actual value that nuclear medicine is providing. And that is also in part because of these theranostics programs. If people are considering working in the field, I would recommend they try and reach out to someone whether that's, me or Stephen. There's a lot more other people listed online from nuclear medicine around Australia, or you could even potentially reach out to like a clinical department and just find someone who's able to give you some insight into the day-to-day workings. But if you're quite interested in like applied science and physics, biology, chemistry, that kind of thing, you'd probably be pretty well suited to a nuclear medicine technologist kind of career and role there.
We were talking before we started this chat about supply chain, and that's kind of another part of the equation. We obviously need nuclear medicine technologists to deliver the treatment, but we also need to have access to the theranostics agents, right? So can you tell me a little bit about what the supply chain looks like? We can talk about Australia or beyond that.
It is an important consideration when developing a radiopharmaceutical, is actually making sure that, we can reliably get these treatments to patients. And a major issue is the availability of radionuclides. And just as an example of the isotope actinium-225, it's shown promising signs as a radionuclide for targeted alpha therapy, but the global supply is quite limited at the moment. And from that clinical perspective, sort of the supply directly affects kind of the treatments you can offer. So even if you do have a highly effective therapy, you can only treat as many patients as you have the isotope available for. And that's kind of one of the reasons actinium-225, despite being very promising, it's still not widely available. So having, that good supply chain is very important. And in Australia, there are initiatives like the Mines to Medicine initiative, which is really exciting and interesting. So it's basically a strategic initiative in Australia, particularly South Australia, aimed at establishing a supply chain for radiopharmaceuticals by converting old mining waste into medical isotopes. And one of our industry partners for Radinnovate, Entex, is actually involved in the initiative. And the goal is to process this mining waste into medical isotopes, and they're looking at supply chains for lead-212 and lutetium-177, and these are both promising isotopes for nuclear medicine and theranostics. So establishing that supply chain is essentially a critical step for developing these radiopharmaceuticals.
Okay, so what kind of mining processes lead to waste that has these isotopes in them?
So for example, uranium, basically leftover uranium stocks from mining can contain a select few isotopes which can be used for radionuclide therapy and in nuclear medicine. And so you can basically develop extraction processes and purification processes where you extract out those useful isotopes from these kind of like uranium leftover waste from uranium mining. So it's an interesting initiative, and it would be good to have, basically a supply chain kind of within Australia to develop these radiopharmaceuticals.
In terms of the supply chain, what are some of the ways that the isotopes that are used in theranostics get produced?
There are various approaches. One is being cyclotron produced. So here in Adelaide at the SAMRI Research Institute, we have a cyclotron, and that produces fluorine-18, which is used for PET imaging.
And then we can also have some specific generators to produce certain radioisotopes. For example, gallium-68, that's also used for PET imaging, can have generators placed on site. And then we can also have other accelerator-produced isotopes like lutetium-177 as well, and other nuclear reactors around the world can produce different isotopes.
Okay, so it just depends on the isotope in question and how it can be produced and what its half-life is. So, how close does it need to be produced to the site of treatment? Is that right?
Yeah, exactly. So some things like, if we go back to the actinium-225 example, that's not produced in Australia. It's primarily can be produced over in the US, is one of the, I think, 3 locations that was producing it for a while there. but that's okay because actinium-225 has a half-life of about 10 days. So that half-life means there's enough time to essentially produce it in the US and then transport it into Australia for treatment.
So this has been a really interesting conversation. I've learned so much from both of you. I'm wondering, are there any final thoughts you wanted to share with our listeners today about theranostics and the work that you both do that maybe we haven't touched on yet?
So I think while we've got established theranostics already for things like thyroid cancer, prostate cancer, there is a lot of research in both Australia and worldwide looking at targeting other cancers that can have lower survival rates. And I think as we overcome some of these supply challenges, it can become quite a promising field for a number of cancers, and we can start looking more specifically at personalising the treatments to the patients if, I guess, all goes to plan and give it time.
Okay, cool. That sounds exciting, especially if people are thinking about getting into this as a field. And Stephen, did you have any final thoughts you wanted to share as well?
I guess just after what Ash was talking about, it's a field that has a lot of growing interest, and so it's a really good time to get involved. And there's multiple pathways into the field, so you can have a background in physics, biology, chemistry, or medicine. So it's really a joint effort across so many disciplines. So yeah, it's definitely a great time to get involved in the area, and there's a lot of interest in the potential for nuclear medicine and theranostics. And yeah, the cool part is it has just a real positive impact on patients' lives. So it's an exciting field and a great time to get involved in the area.
Well, that sounds like a wonderful place to end the episode. Thank you both so much for taking the time to be here today and to share what you do with me and also with all of our listeners.
Thanks for having us.
Yeah, thank you.
Nuclear Matters is a production of the Australian National University College of Systems and Society. We acknowledge the traditional owners of the lands on which this podcast is being recorded on or listened to, and pay our respects to their elders and all First Nations people. If you liked what you heard today, please share this episode with friends, family, and colleagues. If you want to send us some feedback on an episode, please email us at nuclearmatterspodcast@anu.edu.au. Keep in mind that this podcast is intended for information and education only. The views and opinions expressed in each episode are those of the individual speakers and do not represent the official policy or position of the Australian National University College of Systems and Society or the university as a whole.